Okay, check out this complex structure of teriparatide. Don't worry, you don't have to memorize it. I wanted to show it to you because you can identify the carbon-nitrogen background, which is classic for a protein. And that's exactly what teriparatide is. It's the active part of parathyroid hormone. In fact, only the first 28 residues. So how do you think it works? It's given in a pulsatile fashion, once daily subcutaneously. While continuous PTH causes bone to melt away, like we see in hyperparathyroidism, instead, this pulsatile administration actually increases osteoblastic activity and boosts bone density. So what is it used for? Osteoporosis to increase bone anabolism. Are there any toxicities with this drug? Well, some patients have a transient hypercalcemia, which makes sense for this PTH analog. Also, some rodent studies have seen an increase in the rate of osteosarcoma in their teriparatide-treated groups, but this hasn't borne out in human trials.
While we did discuss some of the treatment options for gout in the pathology section, we're now going to go over them here in more detail. The management of gout is chronic, or the time between the flares, and acute, when a patient is having raging pain. Let's reveal a little about the normal pathway for uric acid production. Where do purines come from? Both from our diet and also from native nucleic acid metabolism. These purines are then broken down by xanthine oxidase, which turns them into uric acid. This uric acid goes to the kidney and is dumped into the glomerulus and reabsorbed from the urine at the proximal tubule. In chronic gout, why is allopurinol effective? It inhibits the action of xanthine oxidase, preventing the formation of uric acid in the first place. This causes decreased serum uric acid levels. As we discussed earlier, oncologists also use this drug in leukemia and lymphoma to prevent tumor lysis associated with urate nephropathy. Are there any other drugs that utilize the xanthine oxidase pathway and metabolism? Yeah, think of azathioprine and 6-MP. What would happen if you gave these patients allopurinol concurrently? Well, they might have a buildup of the drug to toxic levels. I keep the mechanism of allopurinol straight in my head, but I remember that it starts with the letter A for antagonist, which helps me remember that it inhibits the xanthine oxidase pathway. There's also a new drug just like allopurinol called febuxostat. How does it work? It also inhibits xanthine oxidase. Would you expect it to have the same drug interactions?
Yeah, of course, because it still blocks the metabolism of 6-MP and azathioprine. Pegloticase is a very interesting drug because it is a recombinant gene that we lost during evolution over the eons. It is a recombinant uricase, and it metabolizes uric acid into a more water-soluble product, allantoin. Animals still have this gene, and there are a lot of theories out there about why humans lost uricase throughout the course of evolution.
Probenecid, on the other hand, is another option for the treatment of chronic gout, and it works by blocking the resorption of uric acid at the proximal tubule. What does that mean for uric acid in the kidney? More passes out in the urine. Interestingly, probenecid also has the side effect of inhibiting the secretion of penicillin, something to be aware of if the patient is on penicillin and on probenecid at the same time. What will happen to penicillin in this situation? Well, it'll have higher serum concentrations. The way I like to remember probenecid and its mechanism is to remember that it starts with the letter P, and it reduces uric acid levels by making you pee the uric acid out, and also blocks penicillin. Okay, colchicine is a drug that is used in acute gout along with NSAID therapy. The idea is that they bind to and stabilize tubulin and microtubules, which decreases polymerization. How does this work out for gout patients? It helps prevent leukocyte chemotaxis, meaning that leukocytes have difficulty getting to the site of inflammation and inadvertently cause more damage. As a side note, remember that certain chemotherapy drugs also work by altering microtubule function, such as vincristine and vinblastine. The problem with these drugs, despite their efficacy, is that they have really horrible GI side effects, especially when they're taken orally. The reason NSAIDs are often used instead is because they have more tolerable side effects.
Glucocorticoids, either oral or intra-articular, are also used for acute gout attacks. No one really knows if steroids even really work for gout. There have been no good trials. However, if a patient fails on NSAIDs and colchicine, try them with good old steroids. What should you absolutely avoid giving in an acute gout flare? Any salicylate. They actually depress uric acid clearance until you get up to about 5 to 6 grams a day. And even these high doses have minor clearance activity.
How would you definitively diagnose gout? Do a joint aspiration, and that should reveal negatively birefringent needles.
The final drug class that will be discussed in this chapter is the TNF-alpha inhibitors. There are 3 of them that you need to know: etanercept, infliximab, and adalimumab. How do they work? They all block the function of TNF-alpha, but do so differently. Etanercept is a decoy receptor that binds to soluble TNF-alpha. You can remember this by remembering that etanercept is a decoy receptor for TNF. What about infliximab and adalimumab? As you can tell from the AB ending, they are actually antibodies. Their antigen is the TNF molecule. Etanercept and adalimumab have the same indications, including RA, psoriasis, and ankylosing spondylitis. Infliximab only differs in that it is not approved for the use of psoriasis. Which of these drugs, etanercept, infliximab, and adalimumab, may be used for Crohn's disease treatment? Only infliximab. As you may remember from earlier chapters, the toxicity of the TNF-alpha inhibitors is that they may predispose to infections because they are modulating an important part of the immune system. So, before starting therapy, what must you do? Place a PPD to test for latent TB. A cool fact is that TNF actually is important in granuloma formation and stabilization, so blocking it can reactivate the disease. Thinking about TB and placing a PPD before starting a TNF-alpha inhibitor will definitely show up on your step 1, so don't miss it.
Let's do some practice questions now. A 27-year-old man comes to the physician's office with a 6-month history of low back pain and stiffness that wakes him up during the night and is worst in the morning. The patient was diagnosed with bilateral sacroiliitis 4 months ago because of his tenderness to percussion of the sacroiliac joints and pain on springing the pelvis up. He has severe limitation of motion in his lumbar spine. Lab tests are most likely to be positive for which of the following? A. Human leukocyte antigen B27, B. Rheumatoid factor, C. Antinuclear antibodies, D. IgM antibodies to B. Burgdorferi, anti-neutrophil cytoplasmic antibodies, or F. Vertebral compression fracture. The answer is A. This patient has ankylosing spondylitis, a chronic inflammatory disease of the spine and sacroiliac joints that often lead to the stiffening or consolidation of the bones that make up the joints. Common findings are low back pain, stiffness over 3 months, pain and stiffness in the thoracic region, limited movement in the lumbar area, and limited chest expansion. Around 90% of the patients are positive for HLA-B27. And common complications include uveitis and aortic regurgitation. Okay, next question. A 17-year-old girl complains of painful, swollen left elbow and fever. In the previous days, her right knee was also swollen and slightly painful. Physical examination is notable for several oral ulcers and an edematous and tender left elbow. Lab tests reveal anemia, a weakly positive ANA, and the results of VDRL testing are positive. The patient is shocked when you inform her that her tests are positive for syphilis, stating that she has no sexual history. Which of the following is the most specific antibody for this patient's condition? A. Anticentromere, B. Antimicrosomal, C. Anti-IgG, D. anti-Jo1, or E, anti-Smith? The answer is E, anti-Smith. The patient has findings suggestive of lupus, arthritis, oral ulcers, fever, anemia, and positive anti-nuclear antibodies. As is the case with many SLE patients, this one probably also has antiphospholipid antibodies. These autoantibodies react to the cardiolipin antigen used in syphilis serology, thus giving a false positive result for syphilis. ANA antibodies are sensitive for SLE, but anti-Smith and anti-double-stranded DNA are the most specific markers for SLE. A 35-year-old woman from Arizona comes to the physician with an X-ray film of her chest taken during a routine health insurance examination. The X-ray film shows bilateral hilar adenopathy. The patient is completely asymptomatic, and sarcoidosis is suspected. She was told that her serum levels of angiotensin-converting enzyme, ACE, were elevated. The sensitivity and specificity of using ACE levels to test for the disease in question are 80% and 50%, respectively. Assuming that sarcoidosis is highly prevalent among residents in the southwestern United States, how would the patient's place of residence affect the positive predictive value and the negative predictive value of the test? A. In areas of higher prevalence, both the PPV and the NPV are lower. B. In areas of higher prevalence, the PPV is higher and the NPV is lower. C. In areas of higher prevalence, both the PPV and the NPV are higher. D. In areas of higher prevalence, the PPV is lower and the NPV remains the same. Or E. Regardless of the prevalence, both the PPV and the NPV are unchanged. For any given test, as the prevalence of the disease increases, the PPV increases and the NPV decreases. Therefore, the answer is B. Alright, next question. A 7-year-old girl has numerous vesicles on her face, particularly around her mouth after falling and scraping her face on the ground. Over a few days, these vesicles turn into pustules and crest over, becoming flaky and light yellow in color. Which of the following statements about the organism most likely responsible for the girl's infection is correct? A. The bacterium is sensitive to bacitracin. B. The bacterium is a facultative intracellular organism. C. The bacterium is alpha hemolytic. D. Sabarod's agar is required to culture this bacterium. Or E. Endotoxin is present in the outer membrane of this organism. The answer is A. This girl has impetigo, most likely caused by strep pyogenes, a gram-positive group A beta hemolytic organism that is bacitracin sensitive. Bacitracin is used to differentiate S. pyogenes from S. agalacti, which is bacitracin resistance, whereas opticin is used to differentiate S. pneumoniae, which is sensitive to opticin, from S. viridans, which is resistant. Impetigo is characterized by an eruption of vesicles on the face. These vesicles later turn into pustules with a characteristic honey-colored crest, which is described as yellow in color here. A distinctly bullous form of impetigo is caused by Staph aureus infection.